Thank you. I've been asked to give a brief talk today on the role of PET and SPECT in brain imaging, in particular on their complementary benefits, the synergies, and the challenges that the field faces with respect to the future and the future of brain imaging studies. This may seem like an odd topic because PET has really been such a powerful tool used in brain imaging studies. And one asks the question is really, what role could SPECT have? And I think SPECT could actually have a very prominent role going forward. It doesn't today, but I think there are reasons for that. And I think in order to understand the reasons for that, one needs to step back in time and look at how these two modalities have evolved over the past 30 years. Now, when I got in the field in the 1980s, PET was largely a research tool. The reason being that the isotope availability was a problem. You needed an on-site cyclotron to produce the radionuclides for used in PET imaging studies. And it wasn't reimbursed either, that the studies that we were doing on a PET scanner, there were no reimbursable procedures. So it was a very powerful research tool, but it was a research-only tool. SPECT, on the other hand, had very widespread availability, largely because of the technetium-99m generator. It was the workhorse of nuclear medicine, and SPECT had a very large presence in the field of nuclear medicine. Let's look at today. It's a very different world today. PET is widely available. Many procedures are reimbursable. SPECT, on the other hand, although it is widely available and reimbursable, it hasn't grown and hasn't enjoyed the growth that PET has had over the past few years. And it's really limited to the studies such as simple studies such as perfusion studies in cardiology, bone scans, and liver scans and things of that nature. It's the level of sophistication of SPECT clearly isn't what PET is today. The reason for that is because there's been a very active R&D pipeline in developing PET tracers for doing very sophisticated studies. However, SPECT really has had no advancement or very little advancement of radio tracer development over the past 10 to 15 years. So how did this happen? Well, there have been a number of breakthroughs, particularly on the side of PET, that really has made it the imaging technique that it is today. The first thing is that FDG, the analog of glucose that measures tumor glucose utilization, proved to be a superior tumor imaging agent. It became clinically reimbursable, and there's no SPECT equivalent. So SPECT is a procedure that PET can do, but there's no way of doing this with SPECT. That, in combination with the availability of medical cyclotrons that reduce the cost of cyclotrons, the availability of automated chemistry systems for doing PET radiosynthesis, made PET a somewhat affordable technique that now a lot of medical centers could afford to do. So the reimbursement of FDG and the availability of the technology for producing the isotopes and doing radiochemistry improved dramatically. And that was the first breakthrough. The second breakthrough is the availability of the whole body PET-CT, which made it very easy to interpret PET scans. And it led to the simplification of scan imaging protocols where you had a very short uptake phase, a very short static acquisition, and you did a very simple form of data analysis called SUV analysis that enabled you to identify tumors, their location, and it's used in the diagnosis and staging of cancer. A more recent breakthrough is the availability of these amyloid imaging agents that enabled PET to move beyond tumor imaging studies with FDG. And this is another reimbursable procedure. And it has really promoted the NeuroPET in the US. But the question I ask is, for these studies, is PET really necessary? And is PET really the only tool that can be used for brain imaging studies? And to answer that question, I'd like to take a closer look at the beta amyloid imaging studies. Now, this is a study using florbetapir. It is looking at the uptake of this tracer, which binds the Abeta Plaques in Alzheimer's patients versus an age-matched control. And you can see visually you have a high uptake of the radio tracer in the Alzheimer's patient, much more so than the control patient. How we do these studies is we inject the tracer We let it accumulate over a 40-minute period or so. And then we have a static acquisition period of around 20 minutes. And we compare the uptake of the tracer in a region of interest and divide it by a reference region, in this case, the cerebellum. And what you get is a measure called the SUVR, which is the ratio of the SUV values in these two regions of interest. Okay, very simple way of analyzing the data, a very straightforward way of acquiring the data, and it has really simplified the PET procedures. The question I ask is, do you need PET? Can SPECT work here? Well, here's an example of an iodine-123 amyloid imaging agent in a SPECT study in an Alzheimer's patient. And you can see you get very good images of these uptake of the radio tracer in the Alzheimer's patients and no uptake in the control patients. So visually, you have good signal to noise ratio, and you can quantify the uptake of the SPECT probe in exactly the same way we did with the PET probe in the prior slide, and that's the SUVR analysis. And you can see in the graphs on the right that you can really see the difference in the uptake of the probe in the Alzheimer's patients relative to the age-matched controls. In this study, they also compared the SPECT tracer head-to-head with fluor-beta pair, and you can see visually the images are very similar. You have high uptake in the Alzheimer's patients with both the SPECT probe and the PET probe. But when you look at the quantitative data, in this case, the SUVR values, the data is very similar, very equivalent. The SPECT probe actually is quite comparable to the data that one obtains using PET. So in this first case, we show that PET actually is equivalent. So for some brain imaging studies, I think SPECT actually can work as well as PET. You know, if you have a case where there's a high target density and a large dynamic range, SPECT will work well. It'll work equivalent to PET. And in the case we just saw in the prior slide, if you have a low target density in a control group like in Abeta, and a reasonable to high target density in the patient group, in the Alzheimer's patient, and your SPECT probe is good enough, meaning having high affinity and low nonspecific binding, then you can get good data. And in this case, SPECT is equivalent to PET. Are there cases where there are advantages of advantages of SPECT over PET? And I think there are. And a perfect example of that is shown on this slide. This is a study out of Mass General where it's using simultaneous injection of two different SPECT probes, an iodine-123 tracer measuring dopamine terminal density, and a technetium agent that measures cerebral blood flow. And if doing the study where you have the appropriate algorithms and you can separate the photo peaks between iodine and technetium 99M, you can actually quantify the uptake of these two isotopes, and you can measure two different things in the brain: terminal density versus cerebral blood flow. This type of study is called a dual isotope study. You can do this with SPECT, but these types of studies simply are not possible with PET because, as you know, all PET isotopes have the 511 keV. So it's impossible to do dual isotope studies with PET. You would have to do those studies on two separate imaging days or sessions, which are often done on two separate days. So another advantage of SPECT, and in this case where SPECT I think has advantages over PET, is that you have the opportunity to do these dual isotope imaging studies. Are there other advances in PET that are worth noting? I think there are, in particular the development of the CZT detector system, which is cadmium zinc telluride. This is a very compact detector system. It enables you to make improved detector design where you can achieve very high spatial resolution for SPECT imaging studies. And an example of that is shown on this slide. This is a study out of the group at the University of Illinois, and it is looking at a very high resolution SPECT scanner that they've developed. It has sub-millimeter resolution. And the data I'd like to point out and draw your attention to are the images shown on the right. These are a series of lymphoma cells that have been labeled with iodine-125 and injected into the brain of a mouse. And they've looked at the cell density ranging from 50,000 cells down to 750 cells. And you can see even in the images with 750 cells, you get very good contrast, very good resolution, and the concentration of radioactivity in this slice is 2.5 nanocuries per slice. So this shows you that because of this improvement in detector design, you can get very high resolution, very high sensitivity, and sub-millimeter resolution. This is another breakthrough that has occurred in SPECT over the past few years. So because of this improvement in resolution and improved detector design, it is theoretically possible to image very small brain structures, such as the substantia nigra, the locus coeruleus, or the dentate gyrus, structures that are virtually impossible, let's say difficult, if not impossible, to image with your standard PET CT scanner. So in this case, PET really does not have this type of spatial resolution that SPECT potentially has, and SPECT has advantages over PET in this regard. The next question I ask is it possible to have the best of both worlds? Can we actually take advantages of having a scanner that can use both PET and SPECT isotopes? We now know we can. There are scanners that can do this. This is the vector scanner that was developed by MI Labs, and it's a scanner that enables you to do simultaneous measurements of a PET radiotracer and a SPECT radiotracer. It's limited to small animal imaging studies, but as you can see in this study, they looked at glucose utilization in the brain using F18-FDG and dopamine transporter density using iodine-123 DAT scan. And you can see with this scanner, you're able to get PET measurements of glucose utilization as well as dopamine terminal density. This is a very powerful imaging technique, unfortunately limited only to small animal imaging studies, but one can imagine the power of this imaging technique if it can be expanded and increased to do human brain imaging studies. Why is this important? And why would a scanner capable of imaging PET and SPECT simultaneously be useful in brain imaging studies? Well, here's a study on the right that is used in Alzheimer's, a typical study in Alzheimer's disease today, where it uses two radiotracers, an Abeta radiotracer, flurbetapir, and a tau imaging agent called fluortaucipir. And you can see in Alzheimer's disease, with Abeta, you get a high uptake of the probe, the Abeta Plaques, which occurs very early in the disease process. And this is a person with advanced disease because you can see there's high uptake of the tau tracer, and tau is typically used to study the progression of Alzheimer's disease to advanced stages. So in this study, two different PET imaging agents are used, both labeled with F18, two separate sessions, often done on two separate days. And we know in this patient population, it can be somewhat difficult to get them to come back for two imaging sessions to do both the Abeta scan and the tau scan. However, if you had a SPECT probe that can take the place of one of these, and one of these I think would be the amyloid imaging agent, you can do this study with a dual isotope study where the SPECT probe and the F18 tau agent can be administered simultaneously, the data acquired in one imaging session, and you can measure Abeta and tau in the same patient on the same day in the same imaging session. That is a very powerful technique. And this is only one example of how this dual isotope study using a PET and a SPECT tracer can be used to provide some very sophisticated studies and do some very elaborate imaging studies. So we think the potential for having PET, SPECT, CT scanners for brain imaging studies certainly increases the level of sophistication of the types of studies and the types of brain imaging studies one can do if these scanners were available. But what are the limitations? Well, from the SPECT side of things, we see we've had great advances in detector design and improvements that led to great small animal imaging systems, but they're not available yet for human imaging studies. So what needs to be done is we need to translate that technology into having head-only scanners, which can be used for brain imaging studies in human subjects. Isotope availability is also an issue, particularly with iodine-123. I think iodine-123 is probably the best radionuclide for developing SPECT-based brain imaging agents. The availability of that is very limited. I think steps need to be taken to try to increase the availability of iodine-123 in order to grow the field. But the field really isn't going to grow, particularly for the SPECT side of things, unless there's effort made in improving in advancing SPECT radio tracer development. This is something that has not occurred over the past 15 years. Many of the studies that you're seeing being used in SPECT studies today were developed 15 to 20 years ago, and this needs to be made a priority. So if we are really going to advance the field of brain imaging, particularly with respect to the ability to use SPECT imaging studies for brain imaging studies, we have to really have better radio tracers than what is available today. So with that, I will end my talk, and but before doing so, I'd like to thank a couple of people, George Zubal and Xiuming Wang, for inviting me to give this presentation for the brain workshop, and Dave Mankoff, Dan Prima, and Scott Metzler at the University of Pennsylvania, who helped me prepare this and gave me ideas as to how to present this talk on this topic. All right. So with that, thank you, and I'll be happy to answer questions.